Welcome to the For Health's Sake podcast, brought to you by Edito Health, elevating digital transformation with a human touch. This episode is sponsored by Radical Health Festival. It's critical to be radical.
Thank you for joining us. My name is Charles Alessi, and I'm one of the co-founders of Edito Health. And I'm delighted you're joining us for this edition of For Health's Sake. And I have with me today Matthew Holt, the author and editor of the healthcare blog. And of course, we all know Matthew as the co-founder of Healthcare 2.0. Welcome, Matthew.
Thanks, Charles. Great to be back with you. Health 2.0, not Healthcare 2.0. There was actually no one did Healthcare 2.0, so maybe I was the founder of that one as well. I don't know.
It's a good question. Has anybody done Healthcare 2.0 other than Health 2.0? There is a subtle or not so subtle difference, but we'll come back to that.
Well, actually, no. I think you can almost start there because Health 2.0 was intended to gather a lot of stuff that was not happening inside the healthcare system. And I guess the question is, has the healthcare system moved on? You know, is a big point. But yeah.
And I think we're starting from there because actually, when we talk about healthcare, how much care does health give? Because if I look at what I used to say 15 years ago around the fact we're on the brink of this great change, and I said it about 10 years ago, and I said it about 5 years ago, and I'm sort of saying it now, and you no doubt are in the same situation insofar as, you know, you've been the portent of change to a large degree, but perhaps we've sort of overpromised and underdelivered. It may be worth reflecting a little bit of what really has changed, because quite a lot has changed, despite the fact that we're still saying sort of the same thing. I mean, what's your take on this?
So, you know, if you go back far enough, so when I was a younger whippersnapper than I am today, in 1997, I read a report with the Institute for the Future on the next 10, actually it ended up being the 13 years of American healthcare through to 2010. I was at the Institute for the Future, and we wrote this on behalf of the Robert Wood Johnson Foundation. There was a huge meeting with a lot of press coverage, and we presented the results of this. And I was responsible for the technology section, and I said, we're about to get to, you know, a change in the use of information technology in healthcare and electronic medical records and data analytics and all this great stuff that will be as impactful as the introduction of, you know, antibiotics. So I made this sort of statement, and it got reported in the Washington Post and all these other things. And luckily, 13 years later, everyone had forgotten about it, because although in some other countries we did start introducing electronic medical records, I mean, in you know, the UK to some extent, especially the Netherlands, Norway, New Zealand, any country beginning with N. We didn't really develop them in the US or install them in the US till the latter part of the 2000s, and then it really happened with the government subsidies that put them in the 2010s in the teens. Now, we also, I think, we're all guilty of thinking that if you added information to the healthcare process, it would change the healthcare process. And I think information technology and information. And I think the answer is that what we've done by adding information technology to the clinician experience really just exaggerated the issues and the problems with the current clinician experience in the US particularly, but I think elsewhere as well. So, you know, now people are doing what they were doing before, but they're recording it better in electronic medical records. I don't think people would want to go back. But at the same time, I think, you know, people like you and I and many others worth saying, well, look, don't also ignore the fact there's this other wider information and communication technology revolution going on outside of healthcare, and that will come into healthcare, and that will involve patients getting access to their data and using tools to manage their health. It'll involve a lot more ease of use of communication between doctors and patients. It'll involve a lot more information being sort of taken from the flow of discussion of patients and being used for medical research and that kind of stuff. And I think a lot of that promised from the late 2000s, that, you know, which was called Health 2.0 back then, you know, digital health now hasn't really come through. So I think, yes, a lot has changed, but I think the way we deliver healthcare, is somewhat similar. And some of the big changes that, I was a proponent for and still I'm a proponent of, in terms of changing healthcare into a much more primary care based, universal population management system using technology haven't really happened, especially not in the US.
Now, this is really fascinating because you touched on something I never even thought of before, Matthew. I was in practice as a primary care clinician at the introduction of computerization within healthcare in the United Kingdom and in the UK. For some strange reason, primary care sort of caught on to computerization before hospitals. So it happened in a somewhat different way.
Right.
And the way I introduced it into my practice, I remember this absolutely perfectly, was I wanted to use it to help me do what I always did. At the time I introduced it, I thought this would be helpful because it would save me having to use index cards, having to use registers, which I had to remember where they were, having to actually update things manually because they would be updated electronically. At no point during the introduction, perhaps it's because I'm just so close-minded, but at no point during the introduction of these systems did I think this would have a fundamental difference on the way I actually practiced. And I'd go further than that. If I had sold it to my partners and my colleagues that this was the start of a fundamental change in the way we practice, I would never have been given permission to go anywhere near one of these infernal machines. Remember, I was pretty damn young in those days.
Can I make a comment? Because in 2000, I think you're probably right, but in 2002 or three, I did a study on international use of computerized medical records. I was working for the Harris Poll at that stage, or I just finished working with the Harris Poll. And I actually ended up in Reading, in the UK, where my dad was a hospital consultant, so he was a specialist, and he introduced me to a couple of GPs who had just put in these records, right? And I was able to go. So what I did was, I think at the time, must have been 2003. You remember Vioxx had just been pulled from the market?
Yes. It had been pulled off because it had adverse.
Right. Well, they were able to show me. The GP was able to show me exactly. He went to his computer, pulled up everybody in the clinic who was on Vioxx. He was also able to show me everyone in the clinic on any other drug. Also able to show me anybody in the clinic who had a diagnosis of diabetes. Whatever, right? These are things that the average non-computerized practice could not have done, right?
Yes.
My assumption was because GPs in primary care in the UK were kind of the main part of the system and always have been. I know that. Let's not go into what that means, but because of the importance of them within the UK system, my assumption was that we were really going to move, and the UK to some extent did, to really trying to look at the overall health of those people with different disease categories. And there were some payments that went on later for people with the GPs who did better getting the diabetic foot exam.
Oh, yes. No, all that worked very well.
But but to some extent, that was kind of what GPs were sort of doing anyway. And I'm not sure it made a big change to the system. Whereas in the US, we kind of tried to adopt those things, which had certainly not been done pre-computerization. And some organizations, Kaiser Permanente notably, did a better job at outreaching to patients and figuring out how to manage the health of people with certain populations. And they'll tell you about their impact on, bed sores and managing people with cardiac problems and et cetera. But I don't think we've actually changed, the way the American system you look at today is still a elective surgery fee-for-service system. And
but
it didn't change that just because we have the computers.
No, I accept that. And Permanente are a quasi-religious organization, of course. We need to remember.
It's a fine cult. It's a good cult. That one's a good cult. There are plenty of bad cults over here.
So we understand that. What actually changed, in my view, and I'm interested in your view, of course, is the fact that the whole world changed outside of general practice to force general practice to change. That is what changed. The fact that that democratization of information started, the fact that the consumer revolution started, the fact that the personalization issues started, that all actually forced primary care to change. Now, the experience in different countries was different to a degree, but there's a sense of a thread which is similar going through all health systems. That's my sense.
Yeah, I agree. So I think the consumerization, which came from the internet, and by the way, started a while before that, right? So if you go back to I read a report in 1995, maybe at Institute for the Future, and it was called Telehealth. And I was trying to describe digital health then. I was trying to say that, yes, I know there is telemedicine. There was some place in Norway where they were, in the north of Norway, they were using some, ICDN line to get back to Oslo and to do a telemedicine. There was the odd prisons in Texas. There are a few places that had telemedicine. But I was saying that wasn't the big deal. The big deal was patients talking to each other and, what later on called online communities. And those started from, even the very earliest, AOL chat rooms and the Well back in those days had people talking about their health conditions. And there was Gilles Friedman and others, running he did ACOR, which is a series of cancer listservs. I mean, ton of information being shared by patients back in the 90s with each other. And then by the time you got to the 2000s, and got the Web 2.0 revolution that made the technology easier, you had a ton of these online activities amongst patients. And then even as you moved into the 2010s, good, bad, or indifferent, you had mostly bad. You had a lot of these groups trapped on Facebook where there was a ton of patients talking to each other. An extraordinary amount of great information captured and exchanged between patients that sadly never really made it into the healthcare system. A little bit, some pharma companies trying to do stuff and recruit for clinical trials and but really we didn't use the patient experience that is now, well known and out there to change how we delivered care. So I would say that you could argue it had an impact on primary care, and yes, primary care physicians had to deal with patients coming in with tons of information from the internet. We've also had, sadly, in the last few years, this massive increase in misinformation, also driven by people talking online and some bad actors there. But I think overall it's not what we didn't get to where I would hope to have got, which is really understanding that patient experience and really changing the way the healthcare system delivered care and managed those people's experience. The healthcare system still does what the healthcare system did, which is manage that little part of it.
Let's take it from here then, Matthew. So what does the industry really need today to accelerate adoption and also, of course, better outcomes, and outcomes not for the clinicians, outcomes for the patients or for the citizens, probably?
I mean, I would say that, go back to the cult that is Kaiser Permanente, and for that matter, the cult that is the British NHS. The goal should be to try to get patients and people, into management programs which reflect their current state of health, right? Most people are healthy. They need to be encouraged to, go for a walk and not eat and drink too much and all that kind of good stuff. And then the next stage of people, the people who are developing early stage disease, need to be encouraged to, to manage that condition. Again, go for a walk, not eat or drink too much, stay on their medication, monitor their activity, that kind of stuff. And we need that kind of interaction. That information should be heading to what I call the continuous clinic, right? And the continuous clinic, in my view, and I'm not the only person who's come up with this, is an organization that is actually monitoring people at their level of acuity wherever they are. Now, you do see this in various places, and usually, this kind of management system is used in intensive care. You see, you get sort of doctors in a bunker managing patients who are actually really sick. I'm saying we should use a combination of staff, AI, as we now have that, and also monitoring devices to manage people where they are. We started to get to this with some of the remote patient monitoring starting to be seen during COVID. But I think the average person, take myself, 60 years old, probably a few pounds too many, maybe on the way to diabetes, maybe on the way to high blood pressure and cardiac problems or whatever, but nothing going on now. Should be, getting pinged and prodded, I don't know, every 6 months or whatever to check up lab tests. Should be being encouraged to be doing, blood pressure checking every couple of months or every couple of weeks or whatever the number is. And that kind of level of activity should be being tracked and monitored by the healthcare system, and they should be noticing when someone goes from that level to the next level up, and intervening there. Right. So I would say that's the kind of thing that the outreach of the healthcare system should be doing. I think the problem we've got is that, and the countries I know best, obviously, the UK and the US, is that the UK is overstressed with dealing with what it's got inside the healthcare system because of the demands on it and, frankly, the lack of funding it's had over the last decade and a half. We won't talk about the politics of Brexit and everything else, but anyway. And the US is still very much dominated as a fee-for-service system where it's in the interest of, and I had this well described to me by a fellow called Derek Street the other night, who actually builds technology that helps hospitals sort of recruit patients. And he said it very well. He said, inside the system, inside the big health systems in the US, the care that goes on is, in by and large, not bad, right? We just wait until somebody gets sick enough that they need it. And then we treat them as my friend and colleague and mentor Ian Morrison says, we treat them as what the Americans call an RVU machine, which is a fee machine. Oh, the more I can do to you, the more money I make. And,
this happens internationally. This happens all over the world. It happened in England with the QOF system, where basically you follow the money. It happens in activity-based systems. But what you described before, I think, is really important, and I just want to reflect on it a little and rephrase that, because what you described is the fact that we need to move to a more preventative agenda. Now, in Helsinki, in May, we'll be talking about the aspiration of the Finnish health system at the Radical Health Festival to spend as much as 50% of their health spend on prevention by 2030. And that means getting people to do more, monitoring them real time, and actually spending more of the time stopping people developing the symptoms. Now, that's a big aspiration. I don't know whether they'll get there, because, of course, with the same amount of money, it means less money going into hospitals. But having said that, I think it's agreed that's where we need to go to. But how are you going to get the adoption to digital health? To do that, you're going to need to get over these issues to do with secondary use of data. How we're going to get that level of trust in the citizen, how we're going to get that level of engagement and adoption, that is the greatest challenge, I would suggest. I don't know whether you agree.
No, you're completely correct. It's a huge challenge, and there are some people somewhere who will not want to enter into this. And you have to hope the concentric circle of the people who don't want to be monitored, the concentric circle of people who are going to get it sick. You have to hope that they're fairly. There's not much crossover, right? My sense is that if it's still a human business, right? And if there is trust between the humans delivering the care and the humans receiving the care, call it patient-physician relationship. It may not be patient. It may use AI. It may use other things, but I think that will change. If there is that trust, at some point, I'm prepared to say, yes, you can have my data because you're going to reward me with better care. And, and I think it's, I don't think it's an outrageous thing to say from a primary care service, doctor, individual human, whether it's the nice person on the front desk or whomever it is, to say, hey, we are really interested and we care about you. And we want to know what happens. We want you to take your blood pressure on a machine we're going to give you. Or we want to, we want you to check in with this mental health app that or you might have your own mental health app that you'd like us to tell us what, we'd like to connect with you. Somebody somewhere would like to have that connection, and to say that if this happens, we will be able to help you much more. And the alternative will be, if you don't care about this, you don't do anything about it, you're going to end up in a few years' time much more likely to have had a heart attack or this, that, the other. And it's not that much of a jump from somebody going to their doctor now. Same thing happened to me. I'm sure it's happened to you, Charles. My GP, lovely guy, said to me about 5 years ago, You got a few pounds too many. Look at the data, blah, blah. Here's a joke. If, you haven't been on a statin, but you might want to think about it. And I'd gone back and forth and heard stuff about people, But in the end, I went on a statin and my cholesterol came down, and fingers crossed my chance of getting a heart attack a lot. To me, it's the same thing. We've done educational studies. We've done some great education over the last decades. I mean, think how well we've done reducing an incredibly addictive drug in our society. We used to have, when we were kids, everybody smoked, and 60-80% of adults were regular smokers of a very addictive substance. And now that number is down in the teens, below the teens in most Western countries. That was achieved by a combination of, yes, paternalistic sort of, you shouldn't do it, taxes, money, incentives. It also achieved by explaining to people that how bad it was for them, and that they could have a better outcome. So I think the healthcare system, I definitely got some problems around COVID with a certain big subsection of the population over the whole issue of vaccines and what have you. It's not necessarily going the right direction for some subpopulations. But in general, I think most people are interested in, staying alive and living healthy and all the rest of it. And would probably, that's the way it's got to be introduced. But it's got to be done in a very human factors-oriented way by trusted people who are probably going to be human beings. And there's probably going to be a combination of doctors, nurses, and other professionals. I think that's how we introduce it. I also think that if you just look at the amount of activity of consumers online outside of the healthcare system, but at Google and elsewhere, looking for information about their conditions, especially if they have one, there's a lot of interest in this. And people aren't looking up, thinking about conditions because they like having them, right? They want to get them dealt with.
Yep. So let's look to the future again now, Matthew, and look to a young startup today. So what a time to start a new initiative. But let's say someone's starting now, and really, with your knowledge around where you think the industry is going to be in a few years from now, what advice would you give a young startup now? And also with the failures we've seen around some of the big startups.
Well, I think, so I mean, to some extent, you have to parse out who failed because they were trying to be, fraudulent or trying to push the envelope too fast, and we're looking, versus who failed because they were actually too early doing what they were doing. But my sense is that there's a couple of lessons. One is, you can't, in general, you can't move too fast. We've seen very few companies grow in digital health, grow successfully very, very quickly. And most of the ones that have been doing something that's been pushing the line or is not sustainable. So I think that I would say you have to be, aware of the pace at which you can go. The second bigger question is, are you as a new startup replacing the incumbents, or are you working with them? And this is a double-edged sword. The people who try to replace them have in general failed, and the incumbents in most countries either have government backing or lots of money, or in the US, both. And so it's very hard to change their business model. And, and you have to look for avenues where you can do something that fits in with you can sell to the incumbents, it fits in with their programs and their practices and their incentives, but it also does some good. And I would be looking for those niches if I was a startup. How can I, work with a health system to identify sick people are going to be sick earlier using AI or what have you, that at once actually, does help their bottom line, but also pushes them and their clinical people to understanding that they can do a better job intervening earlier with those people.
In other words, how can I fill a gap?
Yeah, it's exactly. How can you fill a gap that actually makes sense? So I think for a lot of the clinically based startups, that's one way to go. I go back and forth on the idea of sort of people trying to build essentially technology-based service companies, medical groups. We're seeing still a lot of that in the US. That it's been successful in mental health. You now see several mental health startups which are doing stuff on there that aren't really part of the quote unquote current system. And you're seeing a number who are trying to build this in primary care or in certain specialties like things like migraine or IBS or certain find specialties where it's tough to get care for the right people, and some others in areas where there isn't a lot of expertise. For instance, care for transgender folks or LGBTQ. God, I can't even say it. LGBTQ populations. There
Plus,
are some, plus. Well, there are a number of organizations who are focused on a sort of hybrid model for that, and I think if you think about where there's a small population and it doesn't get a lot of attention in a physical area, can they agglomerate over numerous over states or even over countries and get care from specialists online? I think that's a great place. So I think you'll see those areas start to grow. My take is that the other area which is going to see more activity and when it started to sort of come out from under its shell is this whole idea of care navigation, because we need to support the primary care folks and others who are trying to help patients get to the right place for their condition. And there are times when you need to go past primary care, right? And you need a solution. And we know that there is inherent bias in the system to do more through specialty care rather than perhaps do what's the right thing. And I think we end up improving outcomes if we can do things like substitute extreme physical therapy for back surgery, that kind of stuff. And a lot of that can be done via navigation. So there's a bunch of interesting navigation companies certainly in the US. I mean, the folks like Included Health or Accolade or Transcarent or others who are trying to do that. Right now, that's only for a small population within what we call the commercial population here. People who work for employers. Doesn't go enough to the elderly. Doesn't go enough to people outside people working with big companies. But I think that that combination of trying to figure out how can we help manage transition through the system is something that will grow, and there's I think a lot of interest in that. It's still a small number of people.
Let me push back on something. Sorry, you're seeing me smile quite a bit when you're talking about navigators, because you remind me of one of the very old clinicians that I used to work with. Sadly, this guy is now dead. And he was a wonderful old-fashioned Dr. Finley type GP. And I remember talking to him about navigators being really good to help people navigate through the system. And he had pince-nez glasses, this guy. And I remember him going like this and looking down at me and said, "Charles, you're really quite, you really need to think differently. When something's broken, you don't get somebody to navigate one through the system. You change the bloody thing that's broken." And of course, he was right. But, and there's a big but, it's, I think, outside the ability of each one of us individually to change something which is as big and as complex as a health and care system. And clearly, one needs a navigator to go through a system as it is at the moment. But in the long term, surely we need to make a system far more responsive to the individual.
I agree. I suspect that your former colleague there with his pince-nez glasses probably was a navigator, right? He probably knew all the specialists.
He was a navigator.
He probably got his patients to the right place. He probably really, and I think that we haven't, I mean, that's still, I think, the role of the primary care doc in the UK. But I think in the US and elsewhere, when you have specialists who are not directly connected to the primary care docs and people able to go to specialists, you find a lot of activity going on that is, that is low value medicine. You also have just the complexity of what's going on. When you talk about the complexity of medication now, talk about the complexity of surgery, the complexity of all the things we're talking about, gene therapy, and the radical changes and differences in cancer therapies and all this stuff, it really, to get somebody to the right outcome, given the variance in practice across the board within those specialties. So the right outcome, the right solution, the right outcome for that individual patient. This to me requires a lot of work. And we're not going to get away from that. Now, I don't know who's going to take on that function. Somebody, we talk about somebody has to take on the function of the sort of the monitoring at whatever level of acuity it is that increases people get sicker and getting, making sure that people are being paid attention to. Someone also has to get on get onto this navigation function where something's actually gone wrong. You have a cancer diagnosis, you have severe pain, you have, some severe advanced heart condition, whatever it happens to be, you need to get to the right kind of care. And somebody has to figure out what that is. And I think that's the navigation approach, which I've seen growing. And I'm, that may live within primary care practices, but it may live outside them. It may be a consumer facing thing. And it may be, in some cases, it's been other consumers, right? Other patients.
Wherever it is, it needs to exist, because the system we have is far too complex. I think
I don't think you're going to make it an easy, this isn't going down to, this isn't buying between 5 different airlines getting you to Hawaii the fastest. It's just not like that.
Yeah. So thank you for being radical as well, because I think it's important.
I'm not sure how radical I've been. You're the one who blow the system up. I'm saying we just need to sit within it.
Well, no, I think it's important to be radical, to be thinking in terms of what we need and where we need to go. This isn't about introducing new translation engines to make what's complex look a little bit less complex. This isn't about only ensuring we have the technology we need to be able to see everything at the same time. I think there's the human element within this, and I think this is what we're talking about today.
Yeah.
So
the last thing I'd add, Charles, is I think the other thing, we are going to be surprised about how good AI is at doing the human element. I think that's coming very, very soon. And I've seen a lot of people talking about, things like therapists and in mental health won't be replaced by AI for a while. And I'm going, I don't know, hang out a couple of years, because this stuff is getting very good very quickly.
And
if used well, it can enhance the humanity and the connection that we see.
Yes, it could make what we do well very much better than it is at the moment.
And more available.
Wonderful positive note to end up on. Thank you very, very much for your time. We'll see you in Helsinki. We'll continue this conversation, and hopefully we'll come to some conclusions again as well. So thank you for all the time you've given me.
Thanks so much, Charles. I'm looking forward to the radical future.